I want to start my presentation with a question. If you see this anatomical view, which vein will choose to do a fistula? It is a cephalic vein or antecubital vein which supply both cephalic and basilic veins. Please remember this slide for the two ways. And to answer the question, we have two main factors. The first, what about the maturation of the fistula? And the second, what the incidence of development of ischemic steel syndrome. And I will focus on this point in my presentation. So it is a comparative study between the incidence of ischemic steel syndrome after brachio-antecubital fistula versus the incidence of ischemic steel syndrome after brachiocephalic or brachiobasilic fistula. We have many patterns of superficial veins in cubital fossa, but type 1 and type 2, it is the most common patterns, and in both antecubital vein supply cephalic and basilic veins. We have about 70 to 80% of male and female had type 1 and type 2 variations of superficial veins. Common complication of the fistula: access failure, bleeding, infection, aneurysms, seroma, venous hypertension, ischemic steel syndrome, and cardiovascular complication. Ischemia, it is a reduction of the blood flow distal to the fistula. About 80% of the cases has a reduction in distal blood flow. Only 10% of the cases has mild symptoms which is resolved in few weeks. Only 1 to 2% have a significant ischemia. Please remember, no test can predict development of ischemic steel syndrome. Grades of ischemia: grade 1, grade 0, no symptoms; grade 1, mild; grade 2, moderate; grade 3, severe. We have a wide range of signs and symptoms according to the severity of the ischemia. Diagnosis based on physical examinations. Improvement of the symptoms with axis compression confirms the diagnosis. Duplex study useful for detection of the cause of the ischemia and planning of the treatment. This comparative study, a total 70 patients divided into groups. Group A, brachio-antecubital fistula; Group B, brachiocephalic or brachiobasilic fistula. All patients has diabetes, hypertension, under regular hemodialysis. Duplex assessment pre-operatively: cephalic vein and basilic vein diameter 2 to 3 mm, brachial arch diameter more than 1.6 mm, and a smooth diameter ratio not more than 1. Assessment criteria: third over the veins, palpable distal pulses, signs of ischemia. Duplex study, follow up after 2 weeks, 3 months, 6 months, and 1 year. In brief, our results are: at 2 weeks, 1 patient from group A and 1 patient from group B has mild ischemia which is resolved spontaneously in few weeks. After 3 months, 2 patients from group A has a sign has ischemic symptoms. One of them has severe symptoms, and I will discuss it later on. After 6 months, 1 patient from group A and 2 patients from group B has mild ischemia. After 1 year, no any new cases. Duplex study, normal average volume flow except in one. This is a final results. 8.5% from group A and the same from group B has mild ischemia. 2.5% from the group B has a severe ischemia. This is a case study. Male patient, 48 years old, diabetic hypertension, under regular hemodialysis. Duplex study preoperatively according to our criteria. Patient underwent left brachio-antecubital arteriovenous fistula. Follow up after 2 weeks, no signs of ischemia. After 3 months, patient has grade 3 ischemia with little finger gangrene. We chose to ligate basilic vein, but no any improvement of the symptoms. Ligation of the cephalic vein with amputation of the little finger. Ischemic symptoms disappear with distal pulses. This before and after. Now we are going to finish our study, and I hope it is clear that no difference between two ways to choose cephalic vein and or antecubital vein which supply both cephalic and basilic are the same. So two ways become one way. My home message: brachial fistula don't increase incidence of ischemic stent syndrome. About 10% of the case developed mild ischemic symptoms. Most of them resolved in few weeks. Only 2% of the case might have significant ischemia. Diagnosis based on physical examinations. Improvement with access compression confirms that diagnosis. So thank you for your attention.